Imagine surviving breast cancer. You've endured all the treatments, the surgeries, the sheer fear of it all, and you've finally been handed a life-saving pill to keep the disease away.
Right, it feels like you finally crossed the finish line.
Exactly. But then, a few months in, you realize this exact medication is slowly freezing your hands and your knees into these agonizing, throbbing joints. And just as this is happening, your doctor prescribes a daily intense physical therapy to heal yet another side effect of that very same pill.
Yeah, a therapy that actually requires intense hand dexterity and like a ton of hip flexibility.
Right. So if you're staring at your medical devices right now with stiff fingers, wondering how on earth you are physically supposed to do this, welcome to your custom-tailored deep dive. I'm your host, and with our resident expert today, we are unpacking a massive, often unspoken catch-22 in breast cancer recovery. Specifically, how aromatase inhibitor-induced joint pains directly sabotage pelvic floor physiotherapy for vaginal dryness.
And to figure this out for you, we have pulled a really comprehensive stack of sources. We've got oncology data from the MDPI review, physiotherapy guidelines from the NHS, and clinical insights from specialized centers like Toronto Physiotherapy and PhysioReform.
It's a lot of ground to cover.
It is, but it is a profound everyday reality for so many survivors. And to truly understand what's happening to the body here, we really have to stop looking at these symptoms in isolation. We have to see the mechanics of how these different bodily systems collide.
Because the standard medical advice can sometimes feel like a cruel joke to the patient just trying to follow it.
Mm.
Okay, let's unpack this. We need to start right at the source, which are aromatase inhibitors, or AIs. Medications like anastrozole, exemestane, and letrozole. All the sources point to these as the absolute gold standard for treating hormone receptor positive breast cancer in postmenopausal women. But why are they so effective?
Because they are master deprivers. For hormone-sensitive early-stage breast cancer, estrogen acts like a fertilizer for the cancer cells. Aromatase inhibitors work by blocking the aromatase enzyme, which essentially shuts down the body's remaining estrogen production.
So it drops those levels to basically zero.
Exactly. Near zero. Depriving the body of that fuel drastically reduces the risk of the cancer returning. It's a brilliant, highly effective survival mechanism.
But driving estrogen down to near zero isn't just a localized event. It's a systemic shock. It honestly reminds me of the oil in a car engine.
Oh, that's a good analogy.
Yeah, like you drain the oil to starve the cancer, sure, but in doing so, you dry out the engine seals and you leave all the heavy metal gears grinding directly against each other.
And sticking with that engine idea, without the oil, you get immediate friction and heat, because estrogen is far more than just a reproductive hormone.
Right, it does a lot more than we realize.
It is a systemic modulator. Our oncology sources actually show that estrogen naturally modulates nociceptive pathways, and it tightly controls inflammatory cytokine activity.
Wait, nociceptive pathways, you just mean the body's internal alarm system for pain, right?
Exactly. The nerves that detect damage and send pain signals to your brain. Estrogen normally dampens that alarm system. It also helps drive collagen synthesis, which keeps tissues plump and stretchy, and it actively suppresses inflammation.
So when you remove estrogen entirely,
You trigger a heightened, highly sensitive pain response. You get an immediate spike in background inflammation and a rapid breakdown in the elasticity of soft tissues, literally all over the body.
which perfectly explains the two massive side effects colliding in our deep dive today.
Mm.
Let's look at the seals of the engine drying out first. Clinically, this is genitourinary syndrome of menopause, or GSM. The absolute lack of estrogen causes the vaginal tissues to become incredibly thin, dry, and fragile. They just lose their stretch entirely. The Pelvic Obstetric and Gynecological Physiotherapy Guidelines, the POGP, they note this causes severe burning, daily discomfort, and dyspareunia, which is the medical term for painful sex.
It's totally devastating for a person's quality of life.
It is. It's so severe that painful sex is cited as the reason 55% of women and 61% of men in these relationships avoid intimacy entirely.
Wow. And while the tissues are drying out, the gears of the engine are starting to grind. This brings us to the second side effect, aromatase-induced musculoskeletal symptoms, or AIMS.
Which is such a mouthful, but a huge deal.
It is. The MDPI review shows that between 20% and 74% of women taking AIs experience severe joint pain, stiffness, and myalgia. The OWISE UK and PhysioReform data get very specific here, too. This pain heavily targets the fingers, wrists, shoulders, knees, hips, and lower back.
I really want to pause on the mechanics of that joint pain. Like, why exactly does dropping estrogen make someone's fingers or knees hurt so much?
It goes back to that collagen turnover and inflammation we mentioned. Without estrogen, the ligaments and tendons holding your joints together become slightly more brittle.
Oh, wow.
Simultaneously, the synovial fluid, which is the actual liquid that lubricates the inside of your joints, decreases. Add in the fact that your body's natural anti-inflammatory brakes have been removed, and suddenly, everyday movements cause micro-irritations that flare up into constant, throbbing joint pain.
So you have a patient whose body is essentially fighting a two-front war. They are dealing with excruciating vaginal dryness and pelvic tension, while their fingers, wrists, and knees are stiff and aching.
If we connect this to the bigger picture, the life-saving cancer treatment has inadvertently manufactured two competing physical crises, and this is where the medical catch-22 locks the patient in.
Because the treatment requires what the pain takes away.
Precisely. Because the established, evidence-based treatment for the pelvic crisis demands a level of physical capability that the joint crisis has just stolen away.
Yes, let's look at how doctors try to fix the pelvic pain and dryness. The standard prescription is pelvic floor physiotherapy, or PFPT. And I think there's a massive misconception here for a lot of people.
Oh, absolutely.
Yeah, a lot of people hear pelvic floor therapy and they immediately think, oh, I'll just do some Kegels while I'm sitting at my desk.
Yeah.
But looking at the clinical guidelines from Toronto Physiotherapy and Women's Healthcare, this is a highly physical, intensely active therapy.
It is entirely hands-on. And
Wow.
regarding Kegels, for a patient experiencing pain from GSM, Kegels are often the worst thing they can do.
Wait, really? Why is that?
When vaginal tissue is dry and fragile, it hurts. In response to that chronic pain, women subconsciously clench their pelvic floor muscles. It's a protective guarding mechanism.
So they're already tightening up.
Exactly. Those muscles become hypertonic, meaning they are constantly tight and spasming. You don't want to strengthen a spasming muscle. The entire goal of the therapy is to manually release that tension and stretch the tissue.
Which requires real mechanical force. Let's walk through what the patient is actually being asked to do at home. To cure this, they have to perform internal manual therapy and myofascial release.
Right.
That means actively using their fingers to apply gentle, sustained pressure on the connective tissues inside the pelvis to literally press out the tension. They have to grip and insert medical tools, like these smooth silicone vaginal dilators, to stretch the tissue and maintain its length.
And they are also instructed to internally apply non-hormonal moisturizers like hyaluronic acid every few days.
And the physical demands extend far beyond just the hands and the pelvis, right? The NHS guidelines are very clear that rehabilitating a hypertonic pelvic floor requires whole-body biomechanics.
Yeah, the pelvic floor is the bottom of your core canister. It works in tandem with your diaphragm, your back, and your hips. To get it to relax, you are prescribed specific yoga poses, Pilates movements, and deep stretching.
So you have to literally get down on a mat, open your hips wide, twist your spine, and engage your deep core to manage intra-abdominal pressure.
You do. And the physical therapist is guiding them in the clinic maybe once a week. But the real work, the daily dilator use, the self-massage, the hip opening stretches on the floor, the patient has to physically execute all of that by themselves.
In their own bedroom, every single day.
That is the reality of the rehabilitation. It is a daily physical grind.
This is the collision point. We've arrived at the cruel irony of this situation. If your oncologist has you on an aromatase inhibitor and your joints are screaming, how are you physically supposed to execute this demanding pelvic floor therapy?
You are looking at a prescribed cure fundamentally blocked by a coexisting symptom. Let's examine the exact physical interference, starting with the hands. The OWISE UK data highlights that AI-induced joint pain has a high affinity for the small joints of the fingers and the wrists.
So if you're listening to this and you've never experienced AI joint pain, imagine trying to grip a smooth, tapered plastic or silicone dilator when your fingers are stiff, swollen, and throbbing.
It's practically impossible.
Imagine trying to find the fine motor dexterity to apply a slippery hyaluronic acid moisturizer internally, or trying to generate enough finger strength to press deeply into a tight pelvic muscle for myofascial release. It wouldn't just be uncomfortable. Mechanically, the hands simply cannot perform the task.
They can't. And the interference doesn't stop at the hands. The physio-reform data breaks down how this pain affects the larger joints too, specifically the hips, knees, and lower back. The pain is typically symmetrical, and critically, it is aggravated by prolonged bending, twisting, or getting up and down.
Which is the exact mobility required for the pelvic floor stretches. If your knees and lower back are inflamed and brittle, The idea of getting down onto a hard floor, rolling onto your back for a happy baby pose, or doing a deep, wide, hip-opening stretch, it's going to feel like pure torture.
This raises an important question. How many patients are sitting at home silently abandoning their pelvic floor rehabilitation simply because their oncologist didn't realize the physical therapist was asking the patient to use inflamed, painful
That's
joints?
so true. The medical system historically treats these side effects in silos.
Right. The gynecologist hands the patient a dilator for the vaginal dryness. The oncologist monitors the AI for the cancer. But the patient is alone in their bathroom, crying because their arthritic-feeling hands physically cannot hold the dilator.
And the stakes of that frustration are terrifying. We have to talk about the MDPI source here because they point out a devastating statistic. The discontinuation rates for aromatase inhibitors due to this specific joint pain can reach up to 30%.
1 in 3 women.
1 in 3. They're looking at a medication that actively reduces their risk of cancer recurrence, and they are saying, I can't take it anymore. The joint pain is so severe, they stop the life-saving treatment. And if you add the emotional devastation of failing at your pelvic floor therapy, of feeling like your sex life is over because your hands hurt too much to use the dilators, you are just pouring gasoline on a fire.
It is a tragedy of comprehensive care. When we fail to manage the toxicity of the treatment, we directly compromise the efficacy of the cancer therapy. For that 30%, their quality of life deteriorates so drastically that the preventative cure becomes more intolerable than the fear of the cancer returning.
So we cannot just admire the problem here. If you were trapped in this catch-22 right now, or you're watching your partner go through this, how do you break out of it? How do you treat the pelvis when the hands are compromised?
Well, it requires a highly strategic multidisciplinary approach. And the first, most accessible lever we can pull is timing.
Timing of the exercises.
Yes. The Physio Reform Clinic data provides a fascinating insight into the mechanics of AI joint pain. It features a very distinct period of severe morning stiffness, usually lasting 30 to 60 minutes after waking up.
Why the morning? Why is it worse then?
Think about the mechanics of sleep. For 8 hours, you are mostly immobile. The inflammatory cytokines we talked about earlier, they pool in the synovial fluid of the resting joints.
Oh, that makes sense.
Right. And because there is no estrogen to clear them out and no physical movement to pump that fluid through the lymphatic system, the joints become incredibly congested. When you wake up, the joints are literally swollen with inflammatory fluid. It takes 30 to 60 minutes of movement to physically pump that fluid out and lubricate the joint.
So the immediate tactical takeaway for the listener is never, ever schedule your pelvic floor exercises or your dilator therapy first thing in the morning. If you try to grip a dilator or get on a mat during that window of peak stiffness, you're setting yourself up for failure.
Absolutely.
You have to wait until the mechanics of the joint have warmed up and cleared that fluid. And speaking of warming up, heat therapy is a massive tool here. Taking a warm bath or using a heating pad before you start. The heat dilates the blood vessels, forcing fresh blood into the stiff joints of your hands and hips, while simultaneously relaxing the hypertonic pelvic floor muscles.
It's an excellent passive strategy, but to truly enable the pelvic floor physiotherapy, you have to aggressively treat the aromatase-induced joint pain at its root. The mandate here is treat the joints to save the pelvis.
Okay, I want to dive into the evidence-based strategies for this because I was reading the MDPI review and it completely blew my mind. They state that the single highest leverage intervention for this joint pain is structured exercise, specifically progressive strength training twice a week, lifting weights.
Yes, resistance training.
Which, if I have a patient whose joints are screaming in pain, telling them to go lift dumbbells sounds like a terrible counterintuitive idea. How does that make sense?
It sounds absurd until you look at what estrogen does to muscle. Estrogen is a key component in maintaining muscle mass. When you drop estrogen levels with an AI, women rapidly experience sarcopenia, which is the medical term for muscle loss.
Right.
Think of your muscles as shock absorbers for your joints. When you lose the muscle in your legs, for example, the physical force of every step you take bypasses the muscle and drives directly into the cartilage of your knee. That mechanical overload causes severe pain.
So by strength training, you are rebuilding the shock absorbers. You are taking the load off the inflamed joint and putting it back onto the muscle.
Precisely. You are restructuring the body's biomechanics to protect the vulnerable joints.
That is brilliant. But let's be real, not everyone could just jump right into a squat rack if they are currently in severe pain. What about other therapies?
This is where acupuncture comes in. The MDPI source references the SWOG clinical trials, specifically a major trial by Hirschman and colleagues. They found a clinically significant reduction in joint pain severity for breast cancer patients using acupuncture compared to a sham control group.
And how is that physically working? It's not just magic needles.
No, it's neurology. The current understanding is that acupuncture stimulates the central nervous system, triggering the release of endorphins, the body's natural painkillers, and physically altering how the brain processes those nociceptive pain signals we discussed earlier.
So it changes the pain threshold.
Exactly. Alongside this, nutritional support is vital. If you are going to rebuild muscle to protect the joints, you need the building blocks. Maintaining an adequate protein intake, roughly 1.2 to 1.6 grams per kilogram of body weight per day, is essential.
Okay, so the patient is aggressively targeting the joint pain with strength training, acupuncture, and protein. But while they are waiting for those interventions to rebuild their shock absorbers, the physical therapist has to adapt the pelvic interventions.
Absolutely. The therapy must be modified to respect the current limitations of the joints.
The Women's Healthcare Source has some great practical workarounds for this. If a patient's hands hurt too much to grip a dilator or apply manual pressure, partners can be educated to assist with the internal therapy. It completely removes the mechanical strain from the patient's fingers and wrists.
And if getting down on a hard floor inflames the hips and knees, you modify it to gravity-assisted positions.
Right, you don't have to do a happy baby pose on a yoga mat. You can practice deep, pelvic relaxing, diaphragmatic breathing while sitting comfortably on a soft therapy ball. You can do hip stretches seated in a supportive chair.
The overarching lesson here is communication. The patient has to feel empowered to look at their pelvic floor therapist and say, my hands and knees are compromised by my cancer medication. I literally cannot do the movement you just showed me. We need a modification.
A skilled physical therapist understands biomechanics and can achieve the pelvic floor relaxation without overloading the inflamed joints. Here's where it gets really interesting, though. When you dig into all these clinical sources, there is a beautiful hidden synergy.
Oh, you mean the overlapping treatments?
Yes, the interventions for the joint pain and the interventions for the pelvic floor actually overlap. The MDPI source highlights a pilot study where participation in a structured Iyengar yoga program resulted in clinically meaningful reductions in joint pain and stiffness from the AIs.
And yoga, with its intense focus on deep diaphragmatic breathing, posture, and core-to-pelvis coordination, is arguably the primary non-internal recommendation for relaxing a hypertonic pelvic floor and treating the symptoms of GSM.
It's the ultimate dual-purpose therapy. The structured movement acts as a mechanical pump, lubricating the joints suffering from estrogen deprivation, while simultaneously training the central nervous system and the pelvic floor muscles to downregulate and relax. You are curing the gears and the seals with the exact same movement.
It is the epitome of holistic medicine. We stop treating the symptom, and we start treating the biological system.
We have covered a massive amount of ground today. We've navigated from the molecular impact of aromatase enzymes all the way down to the practical reality of trying to hold a silicone physical therapy tool in the morning. If you take one thing away from this deep dive, let it be this. If you or someone you love are navigating the aftermath of breast cancer, do not accept the narrative that sudden agonizing joint pain or excruciatingly painful sex is just getting older or something you have to silently endure.
It is not a personal failure. It is a biomechanical side effect that requires a proactive, integrated strategy to manage.
So what does this all mean?
It means the era of siloed medicine has to end. You cannot effectively treat the pelvis without considering the hands that are required to rehabilitate it. When medical professionals and patients recognize how the body's systems interact, how the loss of a hormone ripples through cartilage, muscle, and tissue, we can finally design recovery plans that don't force a patient to sacrifice the comfort of their hands to heal the pain in their pelvis.
It's about demanding care that respects the complete living reality of the patient. And as we wrap up, I want to leave you with a final lingering thought to explore on your own. We've seen today how estrogen acts as a master key for the human body. It unlocks joint lubrication, it maintains muscle mass, it preserves vaginal tissue health, it dampens pain signals. When we remove that single master key to starve a tumor, the collateral damage cascades through every room in the house.
It really does.
So as we look to the future, how might the next generation of oncology therapies be designed? How do we innovate treatments that hunt down and target cancer cells with absolute microscopic precision without having to strip that master key from every single lock in the patient's body? It's the frontier of cancer research, and it's something to keep an eye on. Thank you for joining us on this deep dive.